All right. Well, good morning, everybody. Thank you so much for joining us today. I know many others are still coming in. I did want to acknowledge that I see a couple people who raised their hand. I think it could be a high wave, but if you have something you want us to attend to, please go ahead and put that in the chat. Otherwise, we'll get going with our introductions and then we'll get to our speakers. So very excited to have our speakers today and on this topic, homelessness and mental health impacts and strategies for effective care. There are some things on the slide in case that answers some of your questions. We'll get through some of these as well. As I mentioned, I'm Christina Clayton. I'm one of the co-directors of the Northwest Mental Health Technology Transfer Center, and we're very excited that you could be here today. So first, our land acknowledgement. We want to take this time to acknowledge the land and pay respect to the Indigenous nations whose homelands were forcibly taken over and inhabited. And this calls us forever to commit to learn how to be better stewards of our lands and through action, advocacy, support, and education. We'll put a resource in the chat if you haven't heard of Native Land, can help you identify the stewards of your land. But we are absolutely in the University of Washington standing on the lands of the Coast Salish peoples and other tribes and bands in our area. And we're virtual, so we know we're everywhere. So we just want to acknowledge that. Next, introduction to our network. So the MHTC Network is nationwide, started in 2018, supported by, fully funded by SAMHSA, or Substance Abuse and Mental Health Services Administration. And we have 10 regional centers, and we are in Region 10. There's also a National American Indian Alaska Native Center and a National Hispanic and Latino Center, as well as a network coordinating office. And there are similar networks that you've probably heard of for the addiction field and the prevention field. So we cover a lot of topics, and we are most responsible for Region 10, which has, of course, Washington, Alaska, Idaho, and Oregon. Our Northwest Center, has the same goals as the network, which is to accelerate and adopt implementation of mental health related best practices, heighten the knowledge and skills of the workforce, foster diverse alliances and address training needs, and most importantly, offer free publicly available training like today. Our area of focus is evidence-based practices for serious mental illness, but that's not the only thing that we cover. And so we offer newsletters, online courses, webinars, learning communities. We'll get in the chat either now and or later how you can sign up for our event newsletters so you don't miss something in the future. Next, it is always our intention to be mindful in how we use our language to support recovery and to foster respect and hope. We know this is an ever-changing landscape, and what words may resonate for some may not for others, but we just wanted to share that in our network, we created this slide to uphold these values. Next, a little bit of logistics. So you're muted, you're off camera, you probably figured that out by now, but that's because it's such a large audience. And so we will have obviously the recording, the slides, and how to obtain a certificate of attendance if that's interesting to you. And there'll be more info in the chat. As I mentioned, the chat is great for if you have a technical issue, a question about audio or captioning and those kinds of things. But what we really encourage you to do is put your questions for the presenters in the Q&A box. And so that helps me queue those up for the end of the presentation to make sure we have time to do that. And so if no one has put a question in there or you put it in the chat, we'll have to ask you to move it because we can't copy and paste it. I don't know why, but please do throw those in to the Q&A anytime they occur to you, and we'll get to those at the end. Lastly, your feedback is very crucial to our work. And so while we are required by SAMHSA to do this short survey, we actually look at it all the time. How have these trainings been rated and received? They're confidential, aggregated, but we're really excited to always get your feedback. And also a disclaimer, of course, SAMHSA funds us, but they don't have any opinion about our specific content today. But doing the survey helps keep the free training coming. So that's all I'll say about that. All right, well, today's presenters, I'm very excited to have, and I know they'll introduce themselves a little bit more as well, but Stephen Samra was Deputy Director of SAMHSA's Bringing Recovery Supports to Scale. He's also worked in other leadership capacities for SAMHSA's Housing and Homelessness Resource Network, working in projects for assistance in transition from homelessness and services in supportive housing, TA Center. He brings a lot of experience developing and leading peer advisory councils, harm reduction, cultural competence, peer leadership. But I think, as you mentioned, Stephen, your personal experience is really what resonates and drives your work. So after entering recovery in 1999 from homelessness, complex trauma, substance use, criminal justice, and mental health challenges, you began medication-assisted treatment, and you do a lot of work in the field. And so we're just really so grateful to have you here. Will Connolly grew up in Nashville. After graduating from high school, studied theology during his undergraduate years, pursued a master's of theology at Vanderbilt, and really felt called to be helpful to those who stand with their backs against the wall. So he started engaging individuals experiencing homelessness, making connections to housing, entitlements, just sometimes a cup of coffee, which is often what really works. So you worked with leading the SOAR program and Park Center and working on ending homelessness since then. So very, very excited to have you here as well. Before we get to material that you all have, wanted to have a conversation. And so just first off, wanted to make sure you could say hi or a good morning or good afternoon to where everybody is before I randomly go on to those questions.
Well, Christina, thank you so much. And hi, everybody. It is awesome to have everybody here. And I've been watching the chat, and there are folks from everywhere. And I couldn't be happier. So thank you.
Yeah, hello, everyone. And thank you, Christina. It is an honor to be here with Stephen and so many of you. It's incredible to see over 400 folks joining. So yeah, just so happy to be here.
Thank you. So given that our topic today is homelessness, mental health, strategies and effects, and given your really impressive and yet really deep commitment to this work, what path or key moment led to your current role? I mean, I know you have a lot of hats, you're probably wearing a lot of roles, and but how did you come to be doing this in this field at this time?
Will, do you want to respond first, or?
Yeah, I'll go. I'll let you go first next time. So yeah, I've been fortunate enough to have a clear vocation for almost 20 years now. I've worked in homelessness my whole career, and I'm of course wish I didn't have this job, but also I'm grateful to have it. I have a very good therapist, and he and I have been talking about this, like, why did I get into this work? And it goes way back, I think, for me. I started hearing voices when I was a very young person, like in kindergarten. So this might sound odd, but I had a couple of experiences of trauma, some prolonged when I was a child. And I think I felt this deep loneliness because of that trauma, and also because of that, really what I see now as a response to trauma is the voice hearing experience. So I think that those experiences at a young age, I think at worst, kind of made me feel alone and defective. And just different. And I was just kind of, looking for other folks in the world that might feel that way. And I think I've had a preference to people that maybe feel that way. You mentioned theology, and I think that had a big impact on me when I was at Vanderbilt Divinity School. And I'll just close with that, as that environment has very much a liberation theology focus and lens, and the idea there is that if you believe in God, then and use a liberation theology approach, you kind of you see stories about God being on the side of people who are oppressed and marginalized, and so that just resonated with me. And fortunately, a classmate of mine was a street outreach worker at the time, and he let me follow him around, and I got hooked on doing street-based street outreach work. So that's part of my story.
Thank you so much, Will.
Yeah.
Really appreciate the sharing.
And Will, that was fantastic. It also provided background that I wasn't aware of. So that's really cool. Thank you for sharing all of that. And, when I think about my own sort of path that brought me here, it was by luck, honestly. And what I mean by that is I had been in a medication-assisted treatment program. I wouldn't say I was in recovery. I was using the program and stabilizing, but I'd not really heard about and understood recovery. And part of my recovery was that I needed to go to work. And we had recently relocated from Reno, Nevada to Nashville. And there was a job offer in the newspaper that said something to the effect of street outreach worker, needed, gave the job qualifications. And at the very bottom, it said, people with the experience of homelessness encouraged to apply. So I did. And I showed up in a suit because that's how I'd been taught to do this. And I was waiting for the interviewer to show up. And in comes this tall dude in a long, like navy pea coat, covered in dog hair. He looked like he had just gotten out of bed. And he's like, "Hi, I'm Will Connolly. I'm here to do your interview." And
Will.
Yes. And I was immediately like really self-conscious because I was horribly overdressed. And I just, Will brought exactly the demeanor and the calmness to this interview process that he just showed here. And the moment he and I went to a day shelter, I walked into that day shelter and there were, a couple hundred people in there eating lunch and doing their thing. And I instantly knew everybody in that room, and I didn't know them by name. I knew them by experience. And Will and I left that day shelter that day, and the rest is history. And that's how I really got started in this work.
Wow, that is
it's a beautiful thing, Stephen. It's a beautiful thing.
Well, and I too started in street outreach way back in the day, and also had, a guru around Seattle, Craig Rennebaum, who is a pastor,
yes,
faith-based person, but taught everyone in Seattle and beyond how to do this work. So it's definitely a beautiful thing when we can work together. Yes. So given you both have had your varying experiences and you've trained a lot of people, you do this kind of work, this is your calling, and you work with a lot of providers, what can we better understand if you had to pick, this is impossible, right? If you could pick something that has really resonated when you've shared that with people who are wanting to learn more about this topic, and the light bulb goes on and that the next time they meet someone, it will probably go a little better. What's something you could share, that we can understand about the experience of people living on the streets and experiencing all this suffering? And then, on top of that, what's one way we can be, as providers or outreach workers or whatever role we have, more effective?
So I'll go first, since this is my opportunity. I think, let me give you an example. So Will and I, back in about 2008-ish, 2009-ish, somewhere around there, we were going to implement Housing First here. And, both Will and I are massive proponents of Housing First, and we know the value. And we also know that, the challenges and the barriers around even implementing a program like that. And I remember coming home after both Will and I were just dancing and all really excited about this program and about the potential, because, before Housing First, it's still a struggle, but before Housing First, it was super, super struggling. And I remember coming home and I was really excited, and I told my wife how awesome this program was. And she looked at me and said, "So you're telling me that I'm going to pay to put people in housing after I did all the work I had to do in order to afford my housing?" And it really shocked me. And I didn't expect that from my wife, especially. And what happened in that process is that I had to explain what the challenges are when people are homeless and how difficult it is to extricate yourself from that situation once you're there. And if you understand the challenges in front of people who are homeless in trying to just return to community, you'll have a far deeper compassion and understanding about the complexities of exiting homelessness, which is why Will and I and two other people co-founded a street newspaper called The Contributor here in Nashville. And the focus was completely on the challenges and complexities of homelessness. So for me, understanding why people are homeless and how difficult it is, I don't care what the circumstances are for them, it is incredibly difficult to end homelessness once you're there.
Yeah, thanks, Steve. I don't have much to add to that. I mentioned that I've studied theology and that, work in homelessness. Obviously, those are two topics that just activate people when you meet them, wherever you are. And it can lead to all sorts of conversations, some conversations that are fun and others that are not so fun. So I've just learned to try to not get defensive when people are asking me questions that may feel offensive or whatever. It's a complicated issue. It's a reminder to me that I need to be humble and stay, and just think about humility and ways that I can use that value, because while there are obviously things that work to end homelessness, it's so hard to go from concept to implementation and really, get those numbers of folks to move in the direction that we want them to go in. So yeah, I think also just trying to paint the picture, like what Steve was talking about and Stephen was talking about, of just what it's like to experience homelessness, how much time it takes to navigate the system on a day-to-day basis, and how expensive it actually can be to do that, and the effects, the lethal effects of prolonged periods of homelessness. So trying to put whoever you're talking to in the shoes of someone who's experiencing it, and then also occasionally talking about successes and how things go when everything lines up like we want it to.
Thank you so much. And I know this is a complicated situation and story, and that it's not one thing that's going to solve it. I think, I was at the Housing First conference last week, and just, reminding people that people are suffering in whatever ways they are suffering, and how can we expect that suffering to somehow disappear while still living on the streets, right? That seems, in my mind, fairly undebatable. However, I know it's not for everyone else. And so we need to understand, what is it about? I think people don't want to see suffering, and they don't understand the suffering that they're witnessing, and don't understand perhaps that all sorts of things are contributing to what we're now seeing in front of us. And there's the personal, how we can affect one person, how we can affect the system. But certainly, I know when I've done trainings on, motivational interviewing or other things like that, when you say, hey, think of something you knew you needed to change. That's if you had housing and family and support, how long did it take you to change that? It's usually years. And so I think that's, I guess, what I would say is, you don't know what led to this person being in front of you. And so, I guess not making assumptions, and really keeping that compassion and humility, as you're saying, I think is really huge. And recognizing in that trauma-informed way, I wonder what this person has gone through to lead them to this place versus what did you do to get yourself here? Those are just very different ways of approaching. So knowing that we aren't going to solve all that today, I really, really thank you so much for this conversation. It's hard to communicate these concepts because they're nuanced, right? And we know that things work, outreach, medical care, housing, but we just need to keep trying to, I think, tell our story for why this is a critical crisis that is just being left to languish still for a variety of reasons. But thank you so much for this conversation, all the work you do to uplift voices and educate us and remind us of the humane and humanity in this work. And I will now let you take it from here. So thank you so much. I'll stop my screen sharing. Yeah. Let's see here.
Christina, awesome.
Yes.
Thank you. Thank you for the kind words too.
Of course. I can stop screen sharing. I will do that.
Not a problem. Excuse me. And I'll see if I can get us started on this end.
I think you can just take over, which might be better. There you go.
Did we get there?
Yes.
All right. Fantastic. So folks, give me 1 second to get my own technology adjusted. Fantastic. All right. So it's really fantastic to be here. And as you probably all know, I'm Stephen Samra. I'm a senior associate with the C4 Innovations. But probably most important, I'm a person in long-term recovery from homelessness and co-occurring substance and mental disorders. I address those with medication-assisted treatment since 2000. And again, I'm just really excited to be here. I hope we can bring you some value today. I know your time is valuable. So, Will?
Yeah, hey everyone, I'm Will Conley. I'm the CEO of Park Center, which is a nonprofit organization in Nashville, Tennessee. It's so nice to see folks from all over the country. Park Center, we're, I guess, technically a mental health organization, but we don't really care about what particular diagnosis you have. We just try to meet you, as on your journey, wherever you are. We have a fairly large street outreach team. We also own and operate permanent supportive housing and some other types of housing, and have programs that help people get back to work and do all sorts of stuff depending on whatever their goals are. So yeah, I'm also, as mentioned earlier, I also have lived experience of trauma and what is usually called mental health symptoms or just reactions to that trauma. And I've also struggled with addiction over the course of my life, and I believe I know how all of that impacts my work. So anyway, just happy to be here with you and with Stephen.
Awesome, Will. Thank you for that. And we've got a lot to cover. I'm going to get us through this stuff pretty quickly. By the end of today, I'm hoping that folks will be able to recall at least the 3 causes of homelessness, should be able to discuss the risk factors for homelessness and behavioral health challenges, describe structural racism and the impact it has on homelessness, explain why the homeless population was at such increased risk for COVID, identify at least 3 challenges in ending homelessness, restate at least 5 ways to reduce homelessness and mental illness, and then describe the challenges with the VI SPDAT and the criminalization of housing. So we're going to dive in. And like I said, we've got a lot to cover. I'll try to get us through this pretty quickly so we can get to some good Q&A and some discussion as we need to. So I've been doing homeless service work since around 2005. Will, my co-presenter here, is a person who hired me and brought me into this work. And, honestly, it's worse now than when I started. And I suspect a lot of you can say the same thing. And while we know that COVID had a really dramatic impact, we were in serious trouble long before that pandemic hit. And, HUD's 2020 AHAR, the annual homeless assessment report, there's 580,000 folks on the streets in the United States that we're able to count. So people experiencing unsheltered homelessness were usually the most prevalent in cities, but suburbs are really seeing large increases. 30% members of a family with at least 1 adult and 1 child under 18. And there is some good news, it's tiny, but most homeless families were sheltered. 27% of folks who were homeless and residing in shelters, they were kids under the age of 18, and almost 88% of folks who were unsheltered, 24 or older. 60% of folks in 2020 male, African Americans impacted the most. Nearly 4 in 10 folks who were homeless were Black, and veterans are also disparately impacted. It's about 37,000 veterans experiencing homelessness. And look, this is indeed a serious problem, and it's worsening. So, research and studies and anecdotal evidence really helped us understand what's driving homelessness, and it's poverty. And we know the lack of affordable housing and the ongoing effects of structural racism. They conspire with poverty to ensure that folks who are targeted by that racism, well, they get that full impact. And there's something else related to poverty now that has begun to really rear an ugly head. And that is that people older than 50 have the highest risk of paying more than 30% of their income. And 1/2 of renters age 50 and older do pay more. Growing up in poverty with my sister, I just recently had to move her into my home because at 58 and working a full-time job, she can't afford her own place any longer. And we also know that folks, with low income who spend more than 30%, man, they're house poor. They can't save any money. And, there's just a ton of truth in that saying that a lot of us in this country are just 2 paychecks away from being homeless ourselves. And, my oldest daughter, she went to work while she was sick with COVID. And when I asked her why, she said that if she didn't, she'd end up homeless because she couldn't pay her bills. And I suspect there was a whole bunch of people who thought and did exactly the same thing. Because once a person loses housing, the dominoes are put in motion, and everything needed to extricate oneself from that, it just falls by the wayside as the individual struggles just to survive. And, that's my own experience. And honestly, it took quadruple the amount of resources and the supports to even rehouse me. And, all it takes to push somebody to homelessness in these situations, job loss, a divorce, the loss of your transportation, gentrification. And for older folks, it could even be something like a newly adjusted property tax bill that doubles or even triples what they were previously paying. So, again, the bottom line here, the fundamental cause of homelessness is poverty. So I remember clearly, and many of you will likely remember this too, my former CEO, Jeff Olivet, used to just basically shout, if you want to end homelessness, you must put people in homes. And I know Jeff would also say that at its heart, the homelessness crisis is due to a lack of affordable housing. Existing housing stock with the lower rents, it's gone across this country. And it is rare today that properties with rent at levels affordable to lower income individuals are available at all. People who earn less than 30% of the area's median income, these are extremely low income folks, and they are at the highest risk of homelessness. And that's already big trouble for us as providers because, as you can see nationally, 35 units available for every 100 ELI households. That's shocking. This is a serious problem. And if we don't address the crisis level lack of housing, not only are we never going to end homelessness, but we're absolutely going to increase it as well. Now, when we explore whether and how homelessness and mental illness might be connected, it's pretty complicated in two-way sort of relationship. And, the mental illness may lead to some cognitive and behavioral problems that make it difficult to perform normal activities and do that in a way that keeps stable housing. And, certainly I've experienced that myself. The trauma that I've experienced in my lifetime has created really maladaptive coping responses that have caused me, losses of jobs, certainly, evictions, and the things that sort of the frustration and the anger and temper flares that really did make it difficult to perform normal activities, and made it extra difficult to have people hang around with me because of that. There are a number of studies that show that folks struggling with mental illness often find themselves homeless primarily because of poverty and the severe lack of the affordable housing. And that combination is super stressful, and it's really demoralizing, and it leads to a bunch of other challenges. But the biggest one, at least in my life, was increased drug use and what that led to for me. But we also know folks on the street are victimized in violent ways a lot, and it reinforces this connection between health and homelessness. And we know homelessness is a traumatic event, and there's no doubt that trauma influences a person's symptoms of a mental illness. And sorry, folks. And just that experience, whether it's in the past or it's current, is associated with higher levels of psychiatric distress, higher levels of alcohol or substance use, and lower levels of perceived recovery in folks who do have a previous mental illness. I say this a lot, but it bears repeating here. If I ended up homeless today, it's not only doubtful that I would make it a week without self-medicating, it's doubtful I'd make it through the first day without self-medicating, because this experience is that traumatic, and it's that scary, and worse, it's that demoralizing. And when it comes to the justice system, homelessness among people with mental illness can, and it often does, lead to more encounters with police. And the rates of contact within the criminal justice system and the victimization among homeless adults who have severe symptoms, it's much higher than among housed adults who have severe mental illness. And really importantly, homeless adults with mental illness who experienced abuse or neglect in childhood, they're more likely to be arrested for a crime, or worse, be the victim of one. And one of the biggest impacts of homelessness on mental illness is the impact on moms of families. Mothers who have a postpartum depression that first year after birth at a much higher risk for homelessness, or factors that lead to homelessness, like evictions or frequent moves in the 2 or 3 years after that first year. And these aren't the exceptions. These are the norm. And they're happening to a lot of people. I've used HUD's 2015 point in time, their PIP count, where they're talking about 564,000 folks homeless on a given night. At a minimum, 25% of those folks were seriously mentally ill, and about 45% had, a mental illness. And when you think about, there was a 2016 study, 4.2% of US adults have been diagnosed with a serious mental illness. And something is skewed and off here. Now, a lot of unhoused folks have really high rates of chronic and co-occurring health conditions. And, this is in addition to sometimes very significant mental and substance use disorders. And they're all, also almost certain to be dealing with trauma. We know that unhoused children are at a hugely elevated risk for emotional and behavioral health problems. I had childhood trauma. It was severe, complex, and sustained. And essentially, I've had to deal with all of these issues. I'll talk a little bit more about my own ACE score later. But to this day, I am dealing with emotional and behavioral problems that are manifested as a direct result of what happened to me as a child. And I've been in recovery 22 years. When I look at family members who are not in recovery and who have gone through similar things, the trauma and the challenges that are predicted by ACE scores, that for us, that's our reality. And again, these ACEs are common within the population, and 61% of the adults that were surveyed had at least one ACE, and 16% had 4 or more. And females, women, and several different racial and ethnic minority groups, they're at a great risk for experiencing 4 or more ACEs. And most folks, I think, don't realize when you're exposed to ACEs, it's connected with an increased risk for health problems across the lifespan. And I have an ACE score of 9, and basically every prediction related to an ACE score of 4 or more, I've pretty much experienced or dealt with, including experiencing those health challenges as I've grown older. And research has also shown unhoused individuals have a mortality risk. This is just kills me, you guys, 1.5 to 11.5 times greater than the general population. And as I thought about this, it occurred to me that when I left homeless outreach in 2009, and almost every single person I'd supported or engaged that I could still track are dead. I've gone to more funerals as an outreach worker than anybody should ever have to endure. And I worry about my own life being cut short, especially now because I've built this terrific life in recovery. So addressing these challenges is going to require really some significant preventive services that include mental health and substance use and medical care and social supports that are all related to the social determinants of health. All these things are needed for people who are homeless. And it doesn't matter whether there's a diagnosis of some sort. That data from the 2015 AHAR talks about over half of adults living in permanent supportive housing either had a mental disorder or a co-occurring mental and substance use disorder. And we know from our experiences in the opioid epidemic that unhoused people are at super high risk for overdose. And to make matters as bad as we can, the data also shows that unhoused adults 65 and older have a higher unmet need for substance use and mental health treatment when we compare them to younger adults. And the bottom line here is that there is clearly a link between psychiatric disorders and homelessness, but trying to disentangle it all, it's complicated. And it doesn't matter, regardless of that status. People who are homeless, they generally have a history of poverty, social disadvantage, and that includes considerable poverty in childhood, and they also have lower levels of education. And finally, they are also much more likely to belong to an ethnic minority. So I want to talk about this for a minute. In September 2016, my shop, C4 Innovations, launched an initiative, and it was called Supporting Partnerships for Anti-Racist Communities, or SPARC. And C4 did this to understand and respond to some racial inequities in homelessness. And through some research and action in 6 different communities, SPARC began a national conversation about racial equity within the homelessness sector. And the team looked at HMIS data for each SPARC community. They also looked at general population numbers and then poverty population numbers in the United States and then in each one of the SPARC communities. And let me tell you, the results were pretty shocking. About 2/3 of people experiencing homelessness in SPARC communities were Black, 28% white. So you've got almost 65% of Black individuals, 28% were white, 6.9, about 7% Latinx. When these numbers were crunched, about 78% of people experiencing homelessness were people of color. And by comparison, the general population of the United States, 73.8% white, 12% Black, and 17% Hispanic. Black people were the most overrepresented among individuals 18 to 24 who were experiencing homelessness, and that accounted for 78% of this group. This group also had the highest overrepresentation of people of color broadly. 89% of 18 to 24-year-olds are identifying as people of color. More than 2/3, or almost 68% of individuals over the age of 25 were Black. 56% were that were presenting as family members. They were Black. And the rates of Native American homelessness were also very disproportionately high. And in Spark communities, homelessness among American Indian, Alaskan Natives, 3 to 8 times higher than the proportion of the general population. So, clearly, poverty alone doesn't explain this inequity. And the proportion of Black and American Indian and Alaskan Native individuals who are experiencing homelessness exceeds their proportion of those living in deep poverty. And it's important to understand homelessness doesn't affect all racial and ethnic groups equally either. Black and Native Americans in particular, much more likely to become homeless than their white counterparts. And they also face some different and unique barriers to exiting homelessness as well. And, we talked about this a moment ago. Although Black people comprise less than 13% of the general population, and 26% of those folks living in poverty, they account for more than 40% of the homeless population. So again, poverty rates don't explain this overrepresentation. And these demographics, these are appalling. I mean, the vast and disproportionate number of people of color in the homeless population, it's really a sad testament to this historic and the very persistent structural racism that really exists in our country. And, folks, we can't be bystanders any longer. Collective responses to homelessness are going to have to take this inequity into account as they move forward. And they're going to have to revise wherever they can the policies and procedures, and they got to do it through an equity lens. I talked just briefly about this, that homelessness is increasing rapidly for older single adults, and almost half first become homeless after the age of 50. That is terrifying. I mean, that's just terrifying. This challenge, which is already serious, is about to reach another crisis level, and it's likely to be a lot more difficult than what we've seen in the past for a variety of different reasons. But it primarily boils down again to poverty and a lack of affordable housing. So, adults age 50 and older who are homeless and experiencing health conditions, including cognitive and functional impairment, these folks, are getting these conditions 20 years earlier than folks who are housed. And then they use often acute, healthcare services. You show up at the ER to get treatment, and they die prematurely. In the early 90s, 11% of homeless adults were 50 or older. By 2003, 37% were. And right now, about half are. And people age 65 and older, that's the fastest growing age group of people who are homeless. By 2030, those numbers are going to triple. So we know that homelessness is devastating. But for older adults, it is serious, and there are much more significant risks and harm that arise from that experience. So homeless service providers are pretty well aware of the need, and they're usually very proficient in adapting and overcoming many of the challenges that we run into when we are trying to support and house our unhoused neighbors. And they do it on shoestring budgets. A lot of folks use volunteers. Many rely on the generosity of local donors for the funding. And when COVID arrived, that pandemic exposed our most devastating health and social inequities that are really faced by people who are out there on the bricks. And we already know homeless populations experience disproportionate rates of health conditions, stigma, bias, marginalization. And we know too, this often disenfranchises them from the health and social services and the living conditions that would really increase and even potentiate the risk of transmission and worse adverse outcomes. But what we didn't know was to what extent COVID had impacted the already overstressed community of behavioral health providers and that population of unhoused folks. And we know unhoused persons are especially high risk population for COVID. We know poor health is a significant cause of homelessness, and the experience of homelessness creates these new health conditions. Getting treatment for any of it, much more difficult. And that was all in normal times. The impact of COVID drastically reduced access and exacerbated essentially everything negative related to an unhoused person's ability to identify and access treatment, not just for behavioral health stuff, but for their primary care conditions as well. So there were some very key takeaways that we've all learned from the Rona. And, given the vulnerability and the increased risk for folks who are unhoused to contribute to the spread of COVID, we should have been prioritizing those populations in our pandemic response right away. And, unfortunately, it just wasn't the case. And there's a lot of evidence regarding the ability to access and engage homeless communities. This is essential to improving policy and practice recommendations. And the information is going to improve public health outcomes and inform targeted pandemic responses as we move into the future. Ultimately, disaster and crisis response has got to be better. It's got to be more inclusive, and we've got to recognize there's some very unique circumstances of unhoused people within the context of public health disasters. And we need to do this in order to respond appropriately. We just don't do that. And those lessons learned by our community-based organizations, they have some really important implications as we improve future disaster response and crisis response, particularly for people experiencing homelessness.
Hey, Steve, do you mind if I jump in real quick?
Jump in.
Okay.
Sure.
I just want to brag about our street outreach team a little bit. And
Please.
Just by saying that, well, first off, I think I mentioned this, but we have about a 20-person team. And there are basically like 4 different specialties or foci or whatever on that team. Street outreach, just general engagement, is one. And then we do SOAR, which is like expedited disability benefits for people that might need them. And then housing navigation is the third. And then we also have a data team that is part of our homelessness department. So adjustments that were made for COVID, there was a lot of funding coming down from the federal, from HUD and other sources for homelessness, more than we've ever seen really to respond to COVID. And at Park Center, we use that money to hire, basically what you said in the second bullet here, hire a more medically focused and trained team. So instead of just having generalists on the team, we focus on street medicine and really going out to people and trying to provide health services, vaccinations, all of that. Also psychiatric nurse practitioners as well. So kind of doubling down on that, and also using that COVID funding to hire people that have lived experience of homelessness, and just really deepening our commitment to hiring and valuing that lived experience, because engagement, being able to engage people, like, is always an important thing, but just in the context of a pandemic, being able to like relate to others because you have that lived experience is such a helpful thing. Also, having a diverse street outreach team racially and gender identification, all the other stuff too was so helpful as well. So just wanted to mention that.
Will, thank you. And I know that, at the height of this, the pandemic, when most of us were just locked down in the houses, I know that Nashville's outreach teams had put together a pandemic, a sort of pandemic booklet about how best to support, the folks and how to operate in the middle of this pandemic. It's the only resource that I've found yet that really was informing street outreach workers about how to make this happen in their workplace. I'm not bragging on Nashville that they were the best. I'm just saying that it was a really important resource that came at a critical time. And frankly, it's the only one I've seen. I know that there are others, but
yeah. And one more thing, there definitely, there's all sorts of room for improvement in what we do in Nashville. So, but we housed more people. More people found housing than ever before last year. And I mentioned this in the chat too. As far as our data can tell, which is tough, but the homeless population in Nashville actually has a higher vaccination rate than the general population in Nashville, and so that's something that we're proud of, but is also a little disturbing as well. So thanks, Stephen.
You're welcome, Will. Thank you. Christina, did you want to pop in?
Well, yeah, folks are very excited about this topic. And I know some of these questions might be impossible to answer in the time remaining, but we do have open 11 questions. So please let me know when it's a good time and I can start getting those ready for you. Thanks for everybody putting their ideas in there.
That's awesome, Christina. Thank you. I'll try to get us through this. I'd really like to give folks more time for Q&A than I do this whole presentation. So let's get through it. There is some good news that, we know how to work with people who are experiencing homelessness, and we do know many of the things that work. We know unhoused folks bring unique challenges. And as we move forward, honestly, we've got to move from that deficit sort of medical model that, says, what's wrong with you? We can see it and we know how to fix it. And we're the only ones who know how to fix it, to really this whole person approach to care. And we describe what that means and what it actually looks like in the resource from the Housing and Homelessness Resource Center, Whole Person Care for People Experiencing Homelessness and Opioid Use Disorder Toolkit, Part 1, and we're working on Part 2 now. And all of these resources, anything that I mention in here, Christina and Gabriella are going to put that. In fact, I think they're already on the website and available to all of you. You don't need them for the session, but there are some resources there. And as we argue in that toolkit, the person-centered prevention and trauma-informed treatment practices, these are essential when you're working with folks who are experiencing homelessness, because it helps prioritize and address some really complex issues. And providers should be working with the federal and the state and the community, and especially peer-run organizations, to really secure and deploy both supportive services and recovery supports while we try to move folks into permanent housing. And, finally, clinicians have to know how to help individuals access federal or local benefits. And, Will talks about the SOAR programs. It's one of the best in the country. And the whole focus was right here: improve housing stability, give folks an income and some health insurance. And what this also does for us is it's a unique opportunity for us to pair a peer in a complementary relationship with a clinician, because we know that outcomes are better when you use both than whether when the peer or the clinician alone goes for it. And we also know that part of a peer's role is to assist clients with navigating these really challenging systems. So allowing that peer to support this effort informs and really assists the clinician, and it provides this hugely valuable service to the client as well. You can drive through just about any impoverished area of any major or mid-sized city right now. It's going to be clear that this nation is in the middle of a severe homelessness crisis, and the crisis predates the pandemic, and it's going to worsen if we don't have a sustained and robust intervention. And in this, right before the pandemic, 30 states saw a rise in homelessness. And for the first time since we've been tracking the data, more single individuals that are homeless were unsheltered than they were sheltered. And there were more people in families living unsheltered. And, this life is brutal and it's traumatic and is exceptionally demoralizing. It dramatically and it really negatively impacts the people that are forced to live like that. And it also impacts the neighborhoods and the communities. Shelters, yeah, thank God we have them, but they're far from ideal. They only allow short-term stays. Sometimes that's really chaotic and dangerous. And, congregate settings, I mean, they can exacerbate health conditions and, it's challenging. And I can tell you from my own lived experience, if I'd have been on the bricks from COVID, I'd have been blasted, obliterated, and I would have been out hiding in the woods for as long as I could. And I have a feeling there were a number of folks who probably took that approach too. So we've been at this game for a while. And, we now know, there's no doubt, the system alone can't end homelessness. And, we know the complexities and the challenges that we run into. We know how to reduce it too. And Ann Oliva, who is the current Vice President of Housing Policy at the Center of Budget and Policy Priorities, and more importantly, the former Deputy Assistant Secretary for Special Needs from HUD, testified to the House Financial Committees in, I think, February 20th of this year. And Ms. Oliva, her role was overseeing HUD BASH. And she's saying that this robust and rigorous research has shown that housing vouchers are really effective at reducing homelessness, housing instability, and overcrowding, and it improves other outcomes for families and kids. And I know pretty much everybody here is aware of the challenges with vouchers and these long wait times, landlords who won't touch them. So yeah, there's some things we need to do to improve the image. But if we're able to make a lot more of them available and we're able to increase the amount we're paying landlords who will accept them, it's really reasonable to assume that it's going to be a lot more helpful in obtaining housing than what we're doing right now. We all know that vouchers work, but about 1 in 4 eligible families actually get them, and it's because of funding limitations. And this shortfall is one of the biggest gaps in our support system. And it causes families who have these really urgent needs to face long waiting lists. The national average, folks, 2.5 years. There are some cases folks wait more than a decade, and while they're waiting, they get to experience homelessness. And in my own case, my oldest daughter is on a waiting list right now. The despair and hopelessness she feels while in that wait creates its own depression and its own potential cycle of substance use. And then that jeopardizes the ability to even get the housing. So, and due to a long history of racism, including racially discriminatory housing practices, redlining, that kind of crap, Black, Latino, and Native American people are disproportionately much more likely to face severe rent burdens and the homelessness that comes with it. Will, I know that, in Nashville, we struggled a lot with affordable housing. Before I move on from that, I know that Park Center also does this. And I think you're involved in a new effort. Do you want to say a word about that?
Yeah, thanks, Stephen. So I want to mention somebody in the audience, even though he won't like it, but Ken Cravel, I think, is attending today. And he's someone that I was fortunate enough to meet when I first started working in homelessness as a street outreach worker. and one annoying question that he used to ask me was, like, so what? We'd be doing all this engagement and handing out socks and tobacco and, you know, having coffee with folks. And it was kind of like, yeah, but so what? Like, what is this? How is that helping? And it was a really hard question for me because, of course, the services that we provide to help people survive are so important, but they weren't necessarily leading to housing. And I've been guilty over the years of talking about the need for housing and really complaining about the lack of housing and over just, you know, voicing my concern without really presenting, you know, or paving a way to get there, basically, and really just hoping that the developer community will kind of bail us out, or that the government will bail us out. And so at Park Center, like, we're trying to lead in a different way. We still think it's important to communicate the need for housing, obviously, and to help people survive outside. But we're also trying to actually build more deeply affordable housing for people that have 0 to 30, you know, that fall into that 0 to 30% range, because most developers are not focused, obviously, on that group of folks like we are, like you are. Many developers are just making a ton of money with the growth that, you know, is being seen around the country, and especially where I live in Nashville. It's just like gobs and gobs of money that is being made on building affordable housing, quote unquote, but that affordable housing doesn't reach the people that we're talking about today. So as a nonprofit, we're trying to lead in a different way by actually figuring out how to build housing and really developing that skill set, and or partnering, trying to find that developer that wants, you know, that developer that realizes that they're basically part of the problem in terms of creating homelessness, and wants to give back and do more than just donate, and maybe partner with us to build so that we can master lease or do other things. But Park Center, we own and operate about 160 units of deeply affordable housing, and we're trying to increase that number by about 20% over the next 12 months. So it's extremely hard. It's a lot of time, so complicated, and we're competing against all sorts of folks to do it. But obviously we think it's so important, and it's really like a lack of leadership, in my opinion, to not be focused on housing development as a nonprofit that's working in the space.
Will, that's incredibly important, and you know, thank you for what you're trying to do in building, you know, an alternate path towards affordable housing, because it is so complicated, and there's not a lot of incentive for developers to, you know, to take this step. So thank you again. And
yeah.
I want to talk just a minute about what will work for equity, and then I want to make sure we get the Q&A. I'll fly through a few more slides, make sure we're not going to miss anything, and then we'll get the Q&A. But it's really important that we understand that most minority groups in this country, that they absolutely experience homelessness at much higher rates than white folk, and it creates a very disproportionate share of that homeless population. And we know that voucher expansion would significantly benefit people of color, especially folks who are experiencing homelessness. You know, it's the insufficient funding prevents the vouchers from reaching the most folks who are actually experiencing homelessness. And, you know, there's 24 million plus people in low income renter households that are paying more than 30%. And most of those renters, about 62%, are also people of color. And if we can expand vouchers to all the eligible households out there, it'd cut the poverty rate for the Latino folks by 1/3, for Black folks by 1/4, and 1/5 for Asians, Pacific Islanders, and American Indians and Alaska Natives. It also would sharply reduce homelessness, housing instability, and the kind of crowding that comes with congregate living. I don't want to spend too much time here. I do want to mention that people with lived experience of homelessness and voucher use especially, folks, we got to be at the table when policymakers are talking about topics like affordable housing and homelessness. We bring some really critical and important policy and program design perspective to that discussion. And while the bullets on the slide here really encapsulate the comments and feedback that folks with the lived experience of homelessness have provided, we won't cover them, but if you're providing homeless services in any capacity, none of this is going to be a surprise. And I would just add here that when I was providing direct service at Will's organization, pairing up with people who were experiencing active homelessness to locate and engage the population, that provided a super rapid intro to the entire community for me. And it really established my credibility. And those voices, they helped inform almost all of the approach that I use today, particularly when I engage and support people, because their input was just invaluable. I do need to say just a little bit about the resurgence of criminalizing homelessness, because it is really, really taking off. And what I really want to say is the impact around collateral consequences, because those things are really, folks aren't aware, and they increase the punishment in significant ways. But most importantly, they tend to further the cycle of homelessness. What I need everybody to know, there's 40,000 collateral consequences on the books across this country, and some of them are just devastating to forward progress, particularly towards what SAMHSA calls that productive and satisfying life in our community. And those collateral consequences impact anyone with a justice involvement. So imagine how egregious these consequences are for folks who ain't got a pot to pee in or a window to throw it out of. And these consequences impact me too. I've been in recovery 22 years. I have a master's degree. I have a high-level job. I've done consulting work for SAMHSA and Pat. I can't get a job at McDonald's. I can't work at SAMHSA without a waiver. I can't even have a business license in a number of different states. And all these things are still barriers today. Hardly anybody knows about them, and hardly anybody can help you overcome them. This is really the final piece, and it's around some challenges with the VI SPDAT. And I won't spend a lot of time here, but there have been some concerns that were raised, typically, into three different categories: the limited evidence of the validity and reliability, the accuracy of self-reporting to mental and behavioral health challenges, and then there's some fidelity concerns. And the researchers and practitioners have raised issues with the limited degree of that reliability. They don't claim it to be evidence-based, but evidence-informed. And there are clearly challenges here that need to be addressed. I'm not going to dive into the recommendations for policy change, but those are discussed in depth and in the handout titled Spark Report Phase 1 Study Findings. And this is just, the sort of final words here, and I hope folks have found value today. I do want to say that I'm hoping folks will sort of more intently and deeply consider the impact of a very distinct and well-formed subculture that we exist in, particularly those of us who are, who have some trauma backgrounds. These are subcultures of poverty, of homelessness, and addiction, and how those subcultures will play a massive role in shaping the views and the perceptions and the willingness to participate in the larger culture. We spend a lot of time teaching ourselves to be culturally competent, proficient, and humble when it comes to working with our clients. But we've ignored the potent influences that arise out of these subcultures and how they impact recovery contemplation, treatment engagement and access, the recovery supports, and even sustainability in both treatment and recovery services. And I'm going to leave you all with some words from Bill White. And Bill White He's basically the godfather of addiction recovery to a lot of us. And while Bill is focused right now here on addiction, it's really easy to apply these characteristics to every other subculture that we know are impacting our folks on the bricks today. And Bill says that we're dominated by acute care models of addiction treatment that focus almost exclusively on that neurobiostabilization, a short-term detox, possibly medication, but usually either minimal or no psychosocial support. Providers traditionally see recovery as something physical and psychological. And because of that, I got to remind us, we know that the role of culture in the processes of addiction and recovery are influential. And if recovery is for folks a journey between two worlds, there better be a fully developed culture of recovery available that spans the geographic and cultural context, because those cultures play a critical role in the initiation and maintenance of addiction, of homelessness and poverty, and they constitute huge obstacles to our successful recovery. We can become as addicted to the culture as we are to the central sacraments of the culture. And the wide range of needs that get met within that culture, they can be as powerful a pull back to addiction, back into homelessness, as the brain's adaptation to either the presence or the absence of a drug itself. And recovery involves radically altering that person-drug relationship, that person-homelessness relationship, but it also involves changes in one's relationship to the culture that has supported the relationship. So for us, paying more attention to the influence of these subcultures and the ways in which we're able to break through and contrast a route back to the mainstream, it's one of the most important and probably the least understood or addressed aspect of why our brothers and sisters don't come for treatment, whether they're homeless or they're dealing with an addiction or they're struggling with a mental illness or it's trauma, whatever it is. But folks, thank you for letting me share today. Let me turn this over to Will for just a final thought. We'll have Christina throw us some questions with what time we've got left. And again, thank you. Will?
Thank you, Stephen. Yeah, I always learn so much when I'm with you. And so I just appreciate you leading this conversation. And yeah, thank you as well, Christina.
Fabulous.
Oh my goodness. Well, you covered so much information, and I know we have 2 minutes left, so I apologize.
I'm so sorry, guys.
No, this is, you can, well, if you could see in the chat, people are over the moon and so grateful. And I think, having been at the Housing First Partners Conference, I threw a few references into the chat as well. These are the same issues that people are talking about that have been doing this work for a long time, people with lived experience, people who have, not seen the political will and the money behind what we need to do to address not just the crises in front of us, but the structures that lead to these things. I think that's the biggest thing I often think about when people don't know and haven't worked in this field and had the pleasure, as many of us had, of serving people who have suffered and been so resilient, but we're not helping the cause when we don't look upstream, right? As you've said a couple of times, and the upstream may be different than you think. It's not personal responsibility or moral failings or all the things that people I know are experiencing when they want to try to make a solution. So I'm excited and saddened, like you said, Will, that we still have to do this work, but I think it's so important that all of us are here trying to fight the good fight. So what I can promise you all is that we will get all these questions. That's why we asked you to put them in the Q&A. We will get answers to them. We will put some more resources that address some of these things. Thank you, Will, for typing in some of the answers. I did want to just let folks know, you brought up equity, and that's really, really important to us at the center as well. And I want to make sure, are you seeing my screen for our upcoming webinars? Okay, excellent. Sometimes I have 3 screens too. I don't know where they go. But we have a wonderful presenter who's actually going to be addressing equity for the folks working in the field. So So I think our staff will put links to this in the chat. But that's really, really important because there's been such disparities and are such disparities as well as in the workforce. And so that's really important. And then there's a great HUD and SAMHSA National Mental Health Awareness Month webinar series. So we'll get that to folks as well. Connect with us, whatever, that's all fine. I just want to thank you both for sharing the good word, sharing the truth, sharing your experience, which is so powerful. I also am very, very, very grateful that sharing one's personal experience is now seen as a strength versus something to hide, and very, very, how much it informs what we're all doing. And many of us might not call ourselves peer specialists, but we've often been drawn to this field for a reason. And so it's just really, really powerful. So thank you everyone for your time. Thank you for your time today. And I know we're over, but we will get these things to you, and we will see you again, I hope soon. Thank you so much.
Thank you.